Bonjour, hello. I am Josh Mayo at the Intertribal Council of Michigan's National Native Network. Welcome to the National Native Network webinar series on cancer risk reduction in Indian country. This webinar is titled Michigan Tribal Food Access Collaborative. This technical assistance webinar is being hosted by the National Native Network with Indian Health Service Health and Disease Prevention, which offers technical assistance and resources for commercial tobacco prevention and control throughout Indian country, and the Indian Health Service Clinical Support Center. Your presenter today is Michelle Schulte, MA, Project Coordinator, Intertribal Council of Michigan, Incorporated. She has a Master of Arts in Integrated Marketing Communication from Emerson College and a Bachelor of Arts in Communication and Journalism from the University of New Mexico. Michelle is of mixed ancestry and member of the Red Cliff Band of Lake Superior Chippewas. She is a lifelong learner, having worked in both the health and education fields. A large part of her career has been developing programs, conception, implementation, and evaluation. Michelle's efforts as a project director at Intertribal Council of Michigan include work with tribal communities in Michigan to increase collective impact in early childhood systems and food access, requiring strong communication and awareness. We are pleased to offer continuing education credits for participants in this webinar. No commercial interest support was used to fund this activity. This activity is designated 1.0 contact hours for nurses. To obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. By the end of this webinar, participants will be able to, 1, recognize the limited access to safe, nutritious food within American Indian, Alaska Native communities, and 2, build tribal and non-tribal coalitions focused on increasing community resources that promote healthy nutrition and lifestyle. Please type questions in the question box on the lower right-hand side of your screen. Questions will be answered during the last few minutes of the webinar. Thank you, and I'm now handing it over to Michelle Schulte.
Thank you, Josh. All right. I am looking to share my screen here. And we'll just back up a little bit so everybody can see the slides here. Okay, and all of you should have gotten a copy of these. You'll also see that they are in the handouts. You'll see the same webinar presentation here as there are that came with registration. So, yep, everyone, I'm Michelle. And the little correction, I actually do have a Master's of Arts degree, but I think there was a little error in that one. My degree actually is in curriculum and instruction. And then I have 2 bachelor's degrees. One of them is in a health-related field, and the other one is also in elementary education. And so my experiences definitely have been across health and education, which has made for a really dynamic experience in project development, working across disciplines. And that's, one of our learning outcomes for today, to talk about how we build tribal and non-tribal coalitions that focus on increasing community resources and promote healthy nutrition and lifestyles. As well as, we want to take a look at the limited access to safe and nutritious foods within American Indian communities. Again, if anybody has any questions, please type it into the message box as part of the webinar, and we'll get to those as best that we can. And especially at the end, for any that we can't answer immediately, we'll table it for the end and answer them all for you. All right, so in talking about our learning objectives for today, we want to take a look at the issue, which, the number one issue is recognizing the limited access to safe, nutritious foods within American Indian communities. And this map that we're showing in this particular slide comes from the U.S. Department of Agriculture. And one of the terms that a lot of people are talking about today are food deserts and food insecurity. And addressing child hunger, when we look at the Native American population across the U.S., 24% of American Indians, and even in some communities, more than 24 to 50, more than 50% of Native Americans living in tribal communities live below poverty standards. And we can find that in the U.S. Census from 2011. And if you look at things regionally, you'll see those statistics are changed. We know that statistically with the census, Native American communities are often underrepresented. But I'd say that this map gives you a fair designation of where we have higher rates of disparity when it comes to food insecurity. The little map off to the left there gives you an idea, and my experience has been working with tribes in Michigan, but it gives you an idea of how the food disparities in Michigan relate to where all of the tribal communities, the federally recognized tribal communities in Michigan are also located. So if you look at the bottom left-hand side, we have 12 federally recognized tribes. Right where you see those medicine wheels are the main service areas for those communities. And if you were to lay that over top of the map of Michigan in this whole US map, you would kind of see that correlation. When we're looking at current population survey, the CPS from even 2006, 2008, nearly 1 in 4 households, that's about 23% of Native American families live with food insecurity versus 15% of all US households for 2008. So, you know, it's a significant disparity for families. And when you relate that to what health risks come along with that, we're talking about overweight issues, obesity, diabetes, and, you know, getting people physically active once they've already reached a state of unhealthiness. You know, dealing with obesity and diabetes is also a difficult thing. A lot of times, our issues are exacerbated by a lack of access to the healthy food choices and the variety. So let's take a look at a definition of food desert. If at least 20% of your community lives in poverty and at least 1/3 of the residents have to travel more than 1 city mile or 10 rural miles to reach a grocery store, you could be considered living in a food desert. So that gives you a little bit more about this map. Those redder areas are those places where you have much more than 5 to 10% of the population lives in a food desert area. When you get to those darker orange areas, that's 2.5 to 5% of the population. So what is food insecurity? You know, food insecurity it means you have major challenges to accessing food. A large portion of your income is set aside to fund your journey to get food even. Transportation is the issue in a lot of our tribal communities, who the majority live in rural areas as it is. But even in our urban areas, families are often struggling with limited access to resources from the land itself. And they're also struggling with income issues. When you have to make a choice between fixed income line items such as rent or paying insurance on a vehicle so that you can even drive somewhere if you even have a vehicle, or even childcare costs, which can be expensive. A lot of times you'll go for the fixed income because you can skip a meal. And sometimes that's just the choices that families have to make. So many of our families across the U.S. are relying on, many of our low-income families are relying on a number of different resources through that kind of supplement their food insecurities. Across the U.S., tribal communities often rely on food stamp programs, commodity supplemental food programs, and food distribution programs. While these programs are intended to supplement the food needs, the food security for families, it also has created a new reliance on store-bought foods. And with that, there's poor access to fresh produce. A lot of times it's just more convenient to go up to the corner store or even the gas station if that's all you have. And then you have an increased consumption of fast foods, of junk food, soda pop, things like that, which increases the rates of obesity and complications of diabetes. And even just the longer car ride, people are sitting more, they're not getting as much physical activity as they could be. Native children, the prevalence for type 2 diabetes in most Native children, most children across Native communities can be as high as 76% compared to 6% for non-Hispanic or white children. And that too comes from a testimony that was sent before the Senate Committee on Health in 2016. Oh, I'm sorry, July 16, 2008. The Centers for Disease Control and Prevention reported in 2012 that 59.9% of non-Hispanic white adults, both male and female in the U.S. are either overweight or obese, while 71% of Native American adults are overweight or obese. So additional research shows that longer time spent traveling to purchase groceries can have a direct correlation on high body mass and obesity. So in the state of Michigan, we have a few other programs that, you know, a lot of our communities rely on, one of them being a program called SNAP. We also have food bucks, which it's a double up food bucks program, which kind of incentivizes the purchase of fresh foods at the local farmers markets or local produce at the grocery stores. Basically, anybody who has a bridge card or a food assistance card can actually double their money. You know, for every $1 they spend on fresh food or fresh fruits and vegetables or fresh meat, will actually be worth $2 to them. And in the state of Michigan right now, with the farm bill, the cuts being made to the farm proposed for the farm bill, that could be eradicating all of those supplemental programs. There we go. Technical difficulties. So what next? We have to remember the old analogy of, you know, the babies in the river. If any of you have heard that traditional story about, you know, the man standing on the bridge and seeing babies drowning in the water. And in order to get to the solution is not just to save the babies that swim by under the bridge, but to go upstream and find out where they're falling in. And when we think about that analogy, so what is the source of the issue that we're facing with the land deserts or with the food deserts, with the food insecurity? We can point to a number of different things, and a lot of that's, you know, common sense. We all know low-income families, poverty. We know that, you know, they're having the resources available to us close by is an issue. So the disparities are pretty much in your face. But how do we make the change? The way that, you know, the biggest way that we've been able to do it here in Michigan with the Intertribal Council of Michigan and the work that we've been doing is to work collectively. So I kind of want to shift gears then from, you know, focusing too much on the disparities and then get into our second learning outcome, which is, you know, how do we build tribal and non-tribal coalitions to focus on increasing community resources that promote healthy nutrition and lifestyles. And a lot of my work has been about building those collaborations across programs and finding collaborations in disciplines outside of those that we typically work within. So in healthcare, you know, it's also working with schools, it's working with, you know, different professions that you might not have thought of working with in the past, nor ever kind of took time to do that. When we think about institutionalized learning, institutionalized healthcare, and even just the education behind getting certified or getting a degree in those fields, a lot of times those professions have been isolated. But our communities are not isolated, and there's a lot of dynamics to working together. In the light of budget cuts and programs that come and go constantly, the way to be more successful and make lasting change is to work more collaboratively. So that's been a shift over the last 10, 15 years for a lot of different professional fields. When we talk about federal and state funding, that often pits us in competition with each other, either as institutions, as programs, as projects, as communities. And now we're being forced to kind of share the resources that we do have. And in moving from competition to collaboration, we are finding that our money goes a lot farther. We're able to reach to more families than we could in the past. And we're able to get more done with the same number of people. So we're building capacity for our staff as well. One of the first things that we look for whenever we're working on a project is what resources are out there. One of the unique things about working with tribal communities is making sure that the language and the culture and the faces being presented do match the communities that we're working with. We know that as part of the research is, one of those things that really engages the population and the communities that we're trying to focus on. And so I just wanted to share a couple of really common resources that we start with here in Michigan with the tribes. One of those being, of course, the National Native Network. And there are a number of growing resources being attached to the website here, which you can see in this slide, Traditional Food Resource Guide. For people working nationwide, a lot of these resources focus on communities from Alaska, California, the Great Plains, and Portland. So for us here in Michigan, we also, through the Intertribal Council of Michigan, are developing our own resources or taking some of those and adapting them to fit to our communities. And that seems to be making a big difference in how we do our work and how we engage the communities in that work. And I just wanted to share this as our website. So if you want to follow up after the PowerPoint and kind of take a look at some of the resources we have, you'll see here maternal and early childhood services. This is just a few of the things in our resource library. We have a number of different projects that we're working on. And then we also have the Health and Education and Chronic Disease Department, which again, you'll see a list of the number of the different projects. And one of the unique things about Intertribal Council of Michigan is that we were formed back in the 1960s, 1968 actually, as a consortium for all of the federally recognized tribes. Early on, our tribal communities realized that, by working together, we can get more done and we can pull in more of the resources that are needed to try to start addressing the disparities facing our communities. And so our board of directors is made up of all of the tribal chairmen in the state. And if any of you saw the map of Michigan, our tribal communities are spread out, which is also something a little different than some of the other tribal communities, especially when we get west of the Mississippi, where you have bigger plots of land and while the tribal community is spread out across huge plots of land, our tribal communities are often checkerboarded. So the main service area of one tribe may be in the west end of the UP, but they could have a service area that spreads over 5 or 6 counties. And to do our work through Intertribal Council of Michigan, there's often a lot of travel and a lot of coordination. And in Michigan, we are all part of the Anishinaabe Nation, which is actually made up of 3 different tribes. So we have the Ojibwe, Odawa, and Potawatomi. And within those 3 tribes, even though we have very similar history, we have very similar language, we have very similar culture, there are still some very different aspects of each of those things that still keeps us divided. And it hasn't been until the last 6 years that we've really started to see more and more unified efforts across health and early childhood services. And in large part, that has a lot to do with some additional funding and racial equity work that has come through in Michigan with the support of the W.K. Kellogg Foundation. And so, pulling some of those resources, getting some of those private foundation dollars has allowed us to be a little more flexible and responsive to the needs of our community. And in that, we've changed how we worked. So some of how I guess the framework of how we've been working then, and this goes back to, again, let's look at that learning outcome of building coalitions across disciplines and cross professions, is the term that a lot of you will hear is collective impact. I'm just going to skip ahead here. So the definition of collective impact is a disciplined cross-sector approach to solving complex social and environmental issues on a large scale. So contrary to how a lot of us are used to working projects, you know, especially if you've worked under IHS or federal or state grant programs, you have some very specific and sometimes very rigid objectives you have to meet. The reporting is quite substantial. The numbers are quite substantial as far as, you know, how you need to report and spend out. It often can be rigid. But when you're working with collective impact, you are offering yourself some flexibility in your approach, in pulling in resources and working across other projects and programs and services even. So, you know, you're almost alleviating the burden to do more and reach further with the resources you have. I'm going to go further a little bit more, come back to that one. To give everybody a little bit of background, at the Intertribal Council of Michigan, we actually started with comprehensive early childhood system work. We have two projects that started this focus and this work of how do we develop collective impact across tribes and across programs. And we started quite simply with some private foundation funding and did community assessment on what are the barriers for our communities across health, education, and community safety. We kept our focus on early childhood, which was 0 to 8, and just started pulling in resources. So we looked at the services that are available to our communities. We looked at the infrastructure, which is basically, you know, the policy and how adaptive and responsive each of these programs and the policies are. And that created our whole system. And so we moved beyond just looking at, if you look at our early childhood as an education, we're talking about Head Start programs or child care programs. But we also expanded that and looked at Healthy Start programs and tribal home visiting programs. And we essentially meshed all of those projects together. We've got all of our tribal directors together. We've got tribal chairmen speaking the same language across those different programs. For some of the tribal communities, those programs and services already work together, and for some, they weren't even in the same government building, nor even in the same community. So there was a lot of work to work across tribal departments, and it took quite a bit of time to get people comfortable with that. And I'll go a little bit further into more of those successes, but let me back up into our next step, which is doing the same kind of work across health. So more recently, we have a Tribal Food Access Collaborative that we just were funded for 2 years by the Michigan Health Endowment Fund. Our overall goals are to address the health disparities in nutrition and overweight, in health disparities such as nutrition and overweight or obesity, focusing on Native American families with children ages 3 to 11. And 1, we hope to build and strengthen the tribal workforce capacity. 2, improve coordination of care between providers and nutrition educational professionals. And 3, utilize community food access points and culturally adapted nutritional education resources. So basically, we've started our work on early education. We've expanded it to our Healthy Start, our home visiting programs, and really trying to get messages out, collective messages to parents, to tribal leaders, and working with other institutions throughout our community. And now we're trying to increase those efforts through food access. And so the lesson here is, with collective impact efforts that we're doing, it's not so much about building new coalitions as it is building on what we're already doing and trying to expand that work. So the question then becomes, how do we do that? I think one of the things I just want to stop and say, if anybody has any questions, please feel free to type them. This is kind of a new type of presentation for me where it's, I don't have that interaction with the crowd. So if you do have something that you'd like to ask, feel free to send that through. So strategies for collective impact. When we started our work around early childhood and started around the other programs, the Healthy Start, the home visiting child care, those particular programs, there was a certain set of tools that were really helpful in doing that work. And there were 5 conditions that we looked across in seeing what we were doing. You know, what was our common agenda? Each of those programs has a different focus, of course. With Head Start programs, they have standards and protocols, they have their day set up, they have families that they work with, they have their own form of registration. With Healthy Start programs, their focus, of course, is wellness, child wellness, working with the mothers and families. It might be vaccinations, it might be, you know, nutritional services, things like that. And so a part of the work had to be looking at what was the common agenda across all of those programs and services. We used a number of tools to help us find where that urgency, where the main urgency of the issue is. While each project and program or service had its own individual focus and priorities, we had to really kind of meet and search for where that overlap took place. Who were the influential people that really had the biggest voice around these issues or the most knowledgeable about these issues, and where did they cross-sect? What resources were available and what resources were missing? And after we got to the common agenda, we had to kind of look at some other issues. We know that most of those programs rely on grant funding and support, so we had to find some means of shared measurement. And then we looked at some specific activities that we could all kind of work across programs. And then continuous communication and backbone support. So with our Michigan Tribal Food Access Collaborative, even though we're just starting, some of the common agenda items that we're looking at, we're working with 6 of the 12 federally recognized tribes. And right now, some of our main contact people include tribal leadership. We have healthcare directors involved. We have some of the home visiting staff involved. We have some nutritionists involved. We even have some people from youth services involved. Every tribe is dedicating what staff that they can to the project. And we even have, I think, a Head Start director that's involved as well. And from those different perspectives and different views, we are providing education around food access. And we're also getting a view of what the different tribes are doing and what different departments might see as far as those access points for families. And we're creating space through ITC as backbone support to facilitate those conversations to happen. One of our first meetings, grantee meetings, involved not only unrolling the project itself, but also pulling in non-native entities that are also working on food access or working with families on nutrition or might have supplemental services. And we did a group luncheon for people to come together and kind of network and talk about their program. That's something that, you know, a lot of people don't make time for. And, but it was an important part of our project in getting things jump started, because a lot of times in the work that we've been doing, we'll run into, at ITC, we work at a system level, so we're kind of like that middleman between the tribes and the state and the federal agencies often. And I don't know how many times I've been at meetings and tried to work with different agencies that just said, you know, we want to work with the tribes in our area, but we don't know how to approach them. And, you know, it's quite simply just making that time and communicating. And, but the biggest part, even on top of that, is building that trust. And so there is a number of different examples on how to do that across healthcare. So when you're talking about making collective impact in healthcare type programs, the language might be a little bit different. There is an article that is out there, find that, called Microsystems in Healthcare. It was published by the Joint Commission Journal on Quality and Safety in September 2003, written by Kosnick and Espinosa. And it just kind of talks about some of the language often heard in the healthcare systems themselves and how people talk about making change. The theories for change, the collective impact, the ideas are all the same, but how we talk about it is different. And no matter what institution, no matter what profession you might come from, there are some basic themes and stages that when you're looking to make change, when you're looking to improve quality, when you're looking to improve services, that seem to come across all of the work. In this particular article that I just talked about, it really gets into some details, and there's a number of other articles about in the healthcare system, how microsystems are really that agent for change, and they play a critical and essential role in developing and deploying, making the change in the larger system in strategic plans. And I think sometimes as individuals on the front line, you know, we have our nurses, we have our home visitors, we have, you know, even some of our doctors and providers, nutritionists, dietitians, you know, we feel a little bogged down by the system. Every day we're working with clients and trying to make that change. But sometimes that change has to come from top down, and that's where collective impact makes a difference. And so working within our own departments and branching out is one of those areas of change. It's not just about the work that we're doing with the individuals, but on a larger scale. How can we get our department to move and work with other departments to make that change on a larger scale? So in this article from you know, just trying to keep with the language of the healthcare system, there are 6 stages that can be that can be identified as the development of relationship between, you know, what our individual departments or our microsystems might do and how it leads to the change in the bigger system. And that first stage being self-awareness. You know, what is it that your department, that your staff, that, you know, those around you are really doing in the community? What is the value of that work? And who are you reaching? Often, you know, when we're on the ground level, we look at those that we're serving, and there's always that small population that we can't quite reach. How do we get to those ones that can never quite make it to the appointment, that never quite, they're constantly canceling, or, you know, they just don't follow through after, you know, we've gone through the education, we've given them some resources that they can work on making change in their life, and they just can't quite get there. How do we make that change to really get to that next step with the families and those that we're serving? And some of that is that self-awareness. What are we doing? What are our limitations? What are our barriers? And what changes need to be made within that? And we got to think outside the box there. Sometimes that requires us to seek out other departments, other staff who are kind of thinking in the same place we are. You know, when we worked on the early childhood program, trying to improve the early childhood system, and then thus now bringing in our tribal Food Access Collaborative, one of the things we look for are who are those other tribal community departments, who are those state agencies, who are those federal agencies that are also ready for change and are having the same conversations as us. We cannot change an entire system if not everybody in the system is ready. So we work with those who are ready, who are having those conversations, and you just start with simple conversations, simple meetings, and start looking at what needs to be done. You're looking at the barriers, you're looking at what activities everybody's doing. You know, it goes beyond that calendar sharing. And from that, you build a group of microsystems, which start bringing in larger portions of the macro system, the bigger system. And each of those stages, every time you bring in a new division, a new department, a new partner, you are having to look at different themes. One, you're always building trust and building the relationship from trust. Two, you're looking at the constraints and the barriers of those that are partnering with you, you know, those collaborations that are part of that group. And you're also looking at the creation of a common vocabulary. The kind of language that a Head Start educator might use is going to be completely different than how our Healthy Start nurses might talk. It's going to be completely different than how the doctors that are partnering with us would talk. And it'll be completely different than, say, our tribal leaders might be talking, our tribal chairman, many of them may come from a different background and have no education or experience in health or education other than their own personal experiences being on the outside instead of working within the system. So there's always that finding common vocabulary. And then there's also, you know, raising awareness about the work that you do. You know, how is that beneficial to the community? And if you could do your job in the best, you know, if you were to be 100% successful at what you do, recognizing and understanding what that looks like and bringing all those pieces to the table. And then the last part of, you know, the role that everybody plays when we're working collaborative is that facilitation of reciprocal relationships. So, you know, it's not just one person doing all the work. How does our work overlap? And that constant communication about making things happen. In what we've done through the work at ITC, we have a number of different tools that were made available to us. And I'm not necessarily going to go through all of these different little, tidbits and tools about collaboration, but they are in the PowerPoint. And they were some of the lessons that we learned in collaborating through our Tribal Early Learning Initiative, and then now which will help guide us in our Michigan Tribal Food Access Collaborative. And I think I want to just kind of leave the conversation at this time up for some questions and see if there's any place I can take a step back or tie some things together for people.
So if you do have a question, you can type it in the questions box. There is one question currently from a CHR for the White Mountain Apache tribe. Yeah, the question I have is, I am just wondering about the first slide of the USA. Why is Arizona on the no data status with tribes such as Navajo Nation, Hopi Nation, and White Mountain Apache tribes that serve the north and eastern Arizona?
I'm sorry, Josh, can you repeat that question again? Part of you broke up on that.
They're wondering why on the slide, the food desert map, Arizona is showing up as, so much of Arizona is showing up as no data, when that's where like Navajo, Hopi, and White Mountain Apache tribes serve those areas.
Right, yeah. So this source came from the U.S. Department of Agriculture, and I can't really answer specifically that data, but I know a lot of times, even in Michigan, I know some of our data is unrepresented Sometimes the tribal communities aren't always willing to share their data with those researchers that had come in and taken this data. I know I wish I would have put the other one in there too. There's another poverty map that is a little more specific to, it would definitely show more of the data of Arizona and where those are. But this is just an example that kind of shows, the prevalence of a food desert. So I apologize that it wasn't more specific for your communities.
Thank you, Michelle. And I'd also like to apologize to you, Michelle, about the mix-up with your education on the slides.
That's okay.
I'll give it another minute or two in case anyone else would like to enter some questions before we wrap things up.
Yeah, and again, there's, these two topics about food access and about the work that we've done at ITC and how we're making collective impact across programs. I mean, the content within them is so hard to condense down into an hour's time. So I apologize if it felt like I was jumping around. But if you have any questions about either of those, I'm happy to do follow-up after the webinar and, provide you with some of the resources and research that went into some of the work that we've done.
Still don't see anyone typing in any questions right now. Give it maybe another half a minute before I wrap everything up. In case anyone's formulating a thought. Still don't see any questions being typed in, so I will say thank you for attending this National Native Network webinar. We will send a brief SurveyMonkey evaluation by email this week. If you are planning to obtain CEUs for this webinar, complete the evaluation survey in its entirety within the next week. Please visit our website, www.keepitsacred.org, to find this and other technical assistance webinars, as well as many other cancer and commercial tobacco prevention resources for tribe and tribal organizations. We will be posting the archive of this webinar on keepitsacred.org, normally within 24 hours, but it might be a little later this week due to some people's travels. Please follow us on social media for our update on when the webinar is posted and to stay connected with the National Native Network. And there's our social media addresses. Again, thank you for taking the time, and be on the lookout for the survey, which should come out within the next day or so. Thank you again, Michelle, for your wonderful presentation.
Thank you.